This meeting is now being recorded. Hello everybody, welcome to today's COBIC Club webinar with Dr. Arnold Fertig of Cambridgeshire and Peterborough CCG. I do hope you can hear us okay and you can see the slides and see Dr. Fertig on screen. Should you have any problems, please do feel free to email me. You have my email address. It's katrina.darling@cobic.co.uk. So just before I hand over to Dr. Fertig, a couple of housekeeping notes. We will have the presentation split into two sections, I think, today. So first of all, Arnold is going to present on the procurement process, and then he'll be looking at the outcomes framework development. In between the two, we'll have some time for questions and answers. And again, there'll be a Q&A session at the end of the presentation. So we have some questions that have been emailed in already, but should you have any questions during the presentation itself, please feel free to type them in the Q&A pod at the top of the screen. And we'll also have some take you off mute. So all participants are currently on mute at the moment. So during the Q&A session, we'll take you off mute so you can ask any questions you wish directly to Dr. Fertig. So without any further hesitation, I'll hand you over. And as I said, if there are any questions or technical difficulties, please do feel free to email me during the presentation.
Hi everybody, I hope you can hear okay. Just adjust this. So it's a bit odd doing this. I've not done a webinar before, so please forgive me. I'll try and do the best. It would be really great to have a discussion around procurement or not to procure, how you go about setting up services and the outcomes framework. So hope this stimulates lots of questions. So I've been a GP in the Cambridge area for about 32 years and sort of decided to retire a couple of years ago. So this is a slight surprise to me. I decided to take on the role of clinical lead for older people whilst I was on the governing body of the CCG, and then this sort of developed into a procurement and is absorbing quite a lot of my time at the moment. So without more ado, I'm going to move on to the next slide. So what we'll do today is really just go through why older people's service improvement was a priority. My guess it's a priority up and down the country. Why procurement, the procurement process and the outcomes-based contract. So one of the things that we did early on through our management lead, Matthew Smith, was to create a debate about what the critical success factors might look like. And so this slide really, I think, is central to everything that we did in the subsequent 18 months. Again, you know, these are not really rocket science, and it's what we've been all striving for probably for years, but it is still worth putting down as your vision as you're going along. So putting patients first, of course, improving patient experience and service quality, easy to say, as we know, very difficult to do. We're a big CCG. We're the second biggest in the country, as far as I know, and we're divided into 4 local systems. So whatever changes we were going to make needed to be sensitive to local needs because some of the areas are quite different from others. We wanted to move beyond traditional boundaries to deliver seamless care. There's a huge amount behind that, is there not? I mean, I think quite often the NHS doesn't do too badly in its silos sometimes, and patients will often tell me as a GP about a wonderful ward sister or a hospital doctor or even a GP colleague has made a difference to their lives. Where we fall down, of course, is in the organisational boundaries. Support people to maintain independence and reduce avoidable emergency bed days. So therein lies the possible secret about how we're going to make this happen. The only way we can stop the continuous inflow of resources into the hospital is actually to do this very thing In our local area, various audits at our 3 large acute trusts have shown that something like 20% of older people's admissions, emergency admissions, were considered to be avoidable by a panel of GPs and consultants looking at their case notes. Strong leadership, sound governance, resilience and the confidence of commissioners and provider partners. So I think what lies behind that really is that we're looking for a cultural change. So at the moment, I would characterise the way the commissioners relate to providers and vice versa as confrontational, which seems crazy. We're all part of the same health service. The next point should read credible approach to engaging patients and representative groups in design and delivery of services. So that's the nirvana we're all after. How do you actually get the patient voice? And we're expecting a new provider integrator to tell us, we expected them to tell us how they were going to do that and support them in that. And then finally, of course, provide them a sustainable financial model. I'm not really going to tell you anything you don't know. Why was change needed? Demographic time bomb. Roughly 3% of the population of over 65. Sorry, there's roughly a 3% increase in the over 65s. In this particular chart, it's between 2 and 5%, depending upon which age group. And as you know, people over 65 attend emergency department or are at risk of attending 3 times that of younger people. And the likelihood of NHS funding increase to be limited for the foreseeable future. We have a particular problem in Cambridgeshire and Peterborough, and that the national formula suggests that we are significantly underfunded to the tune of about £48 million. The likelihood of us actually receiving that in the next few years is probably fairly slim. Moving on. So further aspects of why change needed. I already mentioned about just disjointed services, poor communication, with a focus on payment by results, on activity levels, bean counting, however you want to put it, which has shrunk community and mental health services and primary care in the last 5 years. I believe primary care has gone down from 9% to 7% of the total NHS budget, as money is drawn into the hospital through the current way that we pay the hospitals. Sometimes, as a GP, you can actually make things happen if you want to put the effort in. You can keep someone out of hospital. But 9 to 5 is really not good enough, or 8 to 6. We really need a service for frail older people that's 24/7. So why procurement? Number of reasons all coming together. It's a huge sum of money. It's £800 million over 5 years, about £140 million a year. A 5-year contract to enable investment early on. Drive innovation and new approaches through a competitive dialogue process, which I think has been very successful, and that the bidders have been well engaged with that. We've learned a huge amount ourselves, and I believe they have. And there's an art and skill in that, in maintaining a level playing field as you go through, listening to their ideas at the outline stage and at the final solution stage, full solution stage, and reflecting back on it in a fair way. Could the service be provided by more than one provider? In our area, the answer is probably yes and no. There was probably no single provider because it's so big and complex that could do it. But theoretically, we've got 3 acute hospitals. We've got incumbent community services and mental health services. So procurement seemed to be the fairest way forward. The legal advice was that we were likely to get a challenge if we didn't go down this route. The positive side of formal procurement process is it does provide pace and a focus and a discipline to deliver the improvement within the set timescales and process. And probably the most important thing of all was to move away from activity towards an outcomes-based contract and a capitated budget for a whole pathway of care. Something new, a new approach, I think, required a procurement in this particular case. There were 60 expressions of interest, 11 organisations completed PQQ, 10 went forward, outlined solutions in January. It's been a long, drawn-out process, so one needs to be aware of that. Evaluation of the outlined solutions was very detailed. Three organisations went through to the shortlist, and 4 solutions were submitted in July. So the competitive dialogue phase was in 2 parts, running up to submission of the outlined solutions and then running up to submission of the 4 solutions at the end of July. The evaluation of the 4 solutions happened during August, and the preferred bidder was announced on the 1st of October. So this required a bit of a military exercise. For example, in the evaluation of the full solutions, there was roughly 90 people involved, 30 of whom were GPs, mostly GPs but some nurses, patient reps, subject experts and managers. We had local authorities also marking the papers, a bit like marking A-level papers for those of you who haven't done this before. The submissions were essentially their response to a number of questions that we put to the shortlisted bidders and the bidders before them about how they would, what their service solution would be for frail older people, what it would be for long-term conditions, mental health, end-of-life care, and so on and so forth. And we did use something perhaps a little bit innovative, so that we didn't get just apple pie motherhood back. We actually gave them 9 clinical scenarios across the various domains of the outcomes framework, and so these were anonymised but real cases that they then had to respond in 1,000 words to tell us how their solution would make a difference to that particular patient and their loved ones. So I mentioned that we announced the preferred bidder on the 1st of October, which was a new organisation, the Uniting Care Partnership, which is sponsored by a large acute trust, Adam Brooks Hospital, and by the local community mental health trust. The 2 other bidders were Virgin Health and a consortium of a private company, United Health, and 2 NHS trusts, and they were runners-up. 3 good, strong bids for the people of Cambridgeshire and Peterborough. We actually signed the contract, I think, fairly quickly, considering we made the announcement on the 1st of October. So the intensive contract negotiations we signed on the 11th of November. I'm not sure if it was at 11 a.m. or not. I think part of the secret for that was by negotiating 3 draft contracts running through the earlier phases, in the 3 months running up to the announcement, where they agreed in principle to the contract, but clearly there were lots of loose ends, hence it took 5 or 6 weeks to reach the final signing. So what's in, and what's the nature of it? So we've basically appointed a new community provider to replace the current one, and something like 1,500 staff will 2P across to them. But more important, they're going to hold the budget for the whole pathway of care, and we might call them an integrator, for patients requiring emergency care aged 65 and over, for mental health services aged 65 and over, and for community health services, but because it's not probably sound to split community services at 65, district nurses for a 64-year-old and one for a 65-year-old. Community services in scope were from 18 onwards. There are various other bits of money, for example, nursing home letters for GPs, some money we spend on voluntary organisations was put into the pool. The contract I mentioned is 5 years with the possibility of extending by 2. We think that as this is a capitated outcomes-based contract, we've hopefully aligned the financial incentives. So instead of incentivising acutes to admit patients they don't actually particularly want to because they reckon they lose money on, but because they haven't got an adequate community partner, they end up admitting many frail older people. So but we pay for that, including that 20% of admissions that are avoidable. Community services on the block, when they run out of capacity, they end up by patients being admitted. So we're realigning the financial incentives, so we're incentivising them to actually, hopefully, maintain people longer at home, give them the choice of being cared for at home. We expect in the contract better clinical outcomes and patient experience. Up to 15% of the contract monies will be linked to successful achievements of the outcome metrics. So that's about £70 million over the 5-year period is at stake for the new integrated provider. Clearly, there are still some formal regulatory processes to go through in the next couple of months. So it's a personal view, so many lessons learned, I think. We did get quite a few things right the first time, other things perhaps we might have done differently. Clinical stakeholders, staff and public engagement is incredibly complex and requires a lot of work. And I think one thing I've learned that although in principle we're all signed up to transparency, it actually requires quite a lot of work to make that happen. There's a sort of clash of procurement and public law, so when you have bids, then there's commercial sensitivity, but when you're dealing with the public, there's a duty for them to be well informed. And you have to manage this. It's a balance of risk in terms of how much is made public. In the end, we made practically everything public, and perhaps we could have done that 3 months earlier. GP ownership is absolutely key and requires repeated messaging and listening and change in response to that. Competitive dialogue actually is a very powerful tool, but procurement clearly generates a huge amount of worry about the privatisation agenda. I mentioned about messaging and listening. I often went back to the critical success factors when one felt a bit lost, and keep those right in the front of your mind. I think being as open as you can with bidders and other stakeholders enables trust, and then sometimes they will give you the benefit of the doubt, when if you're too officious they wouldn't have done so. You need a very well organised core team, and you need a good procurement and external legal and finance teams. There are multiple work streams, very complex, around IM&T, estates, services, outcomes, finance, governance and so on. These all need to be done well, and they need also to be well coordinated. Quite a complex business. Now, one of the things I can't do is actually give you a huge amount of detail about the UCP service solution. They're managing the communications, and they're going to meet up. We have 850 GPs, and their first task is to meet with them and go into detail with them. So in the next couple of weeks, we'll be able to give more detail. But these are some of the high-level things on offer. So for the first time, we'll have a provider in the community with a population approach. So they'll no longer be just reactive, but they'll be proactive. They'll be helping to search out people with at-risk factors for avoidable admissions, social isolation, putting them in contact with voluntary organisations, etc., etc. So a population approach, and that came over strong, actually, in all three bids. And I think, from my experience, is something new. A better organised and supported integrated community team, so a significant increase in face-to-face time of community staff, better mobile working and so on. More access to specialists in the community, hopefully from all three of the main acutes and the fourth acute that we have a significant amount of activity with. Now, we've all heard of multiple single points of access which turn out to be multiple, but there is a determination to deliver a single point of access 24/7 where information is available and rapid response. So the concept is this: if you've identified 2% of your adult population, which for us will be 15,000 patients, and you have a plan, at the moment we've got to 12,000. And if in 3 or 4 years' time we've got up to 3.5%, which is one of the metrics, 50,000 people, when a patient or their carer or clinician rings 24/7 from the emergency department or from someone's home, the chances are, if someone's been identified, there'll be a plan there, there'll be an anticipatory care plan. So sometimes advice can be given. The daughter in London who wants to be called at 3 a.m. to keep her mother out of hospital can be mobilised. It's the same single point of access that will deliver a joint emergency team to get to the patient's house within 2 hours and set up a package within 4 hours. Clearly the usual things of trying to get better in-reach into hospitals and better discharges, better communication. I'm sorry this is so high level. I think underpinning all this will be cultural change. I've seen many times agreements on service redesign, pathways redesign, but actually when you look back, people continue with their old behaviours because they don't have ownership. And so an important part of the bid, a question to them, was how they're going to achieve cultural change, and we're expecting that to happen. We couldn't put clearly primary care, most primary care, or unfortunately local authorities in scope, but we worked hard to bring the shortlisted bidders together with primary care and local authorities, and that's continued through this early mobilisation period. So those relationships will be key, in which the CCG will help. So some next steps. I mentioned TUPE, I've mentioned stakeholder engagement being absolutely critical, so that's going to be a major campaign ongoing. Work with that list of people there. So the integrator will have really important subcontracts with the 3 acutes, with 4 acutes. The success or otherwise might depend on the nature of that, but so far it's auspicious and there seems to be a willingness to change. It's a win-win, I think, because most of the acutes say that they'd much rather these complex frail people were either not admitted, or if they were admitted for an assessment, they could be sent home in 4 hours or 24 hours instead of sometimes 6 to 10 weeks. There's going to be very close working with 111 and the ambulance service very early on, so that the joint emergency team will be mobilised when a 999 call or 111 has been made and it's appropriate to mobilise a jet team. So I'm just wondering if I might stop there before going on to the outcomes framework, and we could hear questions from you direct if you unmute your phones and then mute them again after you've asked the question. And
all guests have been unmuted.
I'd be interested in how you brought in the GPs into the process.
So that's a very good question. So I think starting, it's quite complicated, isn't it? Because GPs are both commissioners and providers. I'm not sure anyone's cracked this. I'll be interested to hear if anyone has, because it's often the same GPs who are representing both angles. So our governing body has 9 GPs on it. They're in the majority. And I think without their leadership and agreement and ownership, this wouldn't have gone through. Behind each of those GPs is a local commissioning group of between 4 and 28 practices. And again, we had multiple roadshows going out perhaps 3 times during last year and the end of the previous year, going out explaining how far we've got with our thinking and giving them an opportunity to shape. So as far as we can, to give them ownership of what's been happening. Lots and lots of very useful firm pushback and feedback from general practitioners. Many will say they've heard it all before. Of course, they're in crisis. Even if there is more money, how are they going to get the personnel? What's it going to feel like for them with service commencement on the 1st of April? And it's really just a matter of hearing and listening and doing speed dating with our bidders, with the GP. So we did various things. I could go on quite a lot on this particular question, but to cut it short, we brought the bidders together with 12 GPs organised by the LMC. We brought the bidders together with all of our local commissioning group boards. We had GPs in all of the main dialogue meetings. So the main dialogue meeting about the outline, about the main solution, there was roughly 12 of the bidder team in the room, and on our side there were sometimes as many as 15, of which 8 or 9 were general practitioners. So it wasn't. I wouldn't say it was easy, but I think we've got there.
But any increased GP activity would be funded through a local commission service rather than any risk sharing.
So the intention is to have an integration care board in each of our 4 systems. This will be run by a Uniting Care Partnership, so they'll do the minutes and the support. It'll have the stakeholders on it, the local hospital, GPs and so on. It'll have GPs on it as local commissioning groups and GPs on it as providers. If there is a business case for general practitioners to do more, then it's something that will go to this local integration board to see if it makes sense for Uniting Care Partnership to spend money into primary care. But I think what's more important is not so much the money, it's about the communication and how each party relates to each other. By the way, we've used the £5 per head, which we're launching next month, to provide 2 things: a clinical lead for older people for every practice. So that's a named doctor, 108 practices, 108 things. The new integrated link with. And number 2, we're paying GPs to provide a more urgent response service for the frail older people. We've not stipulated times they have to meet in order to get the money. We're suggesting they triage calls within a quarter of an hour of these frail people and try and get someone into the house within 2 hours if they need a visit. But we're allowing each practice to develop its own time targets as it builds up over 12 months.
Thank you.
Any other questions? So I've got some questions in front of me. How was the budget developed to only include care? That's for the over 65s. That's from Brian Mulder, thank you. How was it developed? So I think it's fairly straightforward for the acute trust. Correct me if I'm wrong, some of you may know better. It's more complicated for community services and sometimes we had to make some estimates about how to split the service. But all of, because we went in the community service for 18 plus, we were able to put all community nursing, for example, into scope. Someone's asked, what about, for example, a 16-year-old requiring adult community nursing? So there is some money in the contract for that. I've got another question here. What are providers paid if they admit, and how does this differ from incentives not to admit? Pamela Leveny, thank you. So the CCG will not be paying PBR because it's giving a capitated budget of 140 million to the new integrator. They will be having subcontract with our 4 acutes, 3 main ones, and a smaller one. It's possible the acutes will insist on PBR. I think the contract is still highly viable. But I think it looks like they may be able to do some partial risk sharing with the acutes, who, as you know, lose money once they go over the 2008-2009 baseline in terms of numbers. So the ideal world would be that the acutes give up PBR either this year or next year for the 5-year period. We wait and see. All 3 bidders had negotiations of sorts with the acutes prior to their submission of the full solution. And Uniting Care Partnership has obviously energetically re-engaged with the acutes since they were announced as being the preferred bidder. So we're waiting to see the nature of those contracts. But I think there is a win-win for the acutes and an opportunity for them to make a change here. Third question is, has primary care changed how they deliver their service as a result of this new service? So the new service is due to be launched on the 1st of April. I've already explained how we've aligned the £5 capitated budget offer, which we're calling a locally commissioned service to general practitioners, really as a mark of good faith about how we're aligning as much as we can outcomes across organisational boundaries. So we're incentivising GPs to have a service where they can respond a little bit quicker to frail older people. We know that emergency departments peak for 999 frail older people is between 4 and 8 p.m, which is a very inefficient time of the day for them to arrive. So we're hoping to see a change in that. Any other questions about this first part?
Just as whether you considered adding planned care for the over 65s into the contract.
Yes, we did. We've been criticised for not including it. There are complications for doing that. It's increasing the size significantly. What we've said is it's something that we would consider further down the line once we've launched with this. There are clearly boundary issues. When does non-elective become elective? An example of that might be someone going in, 92-year-old, with a stomach hemorrhage, requiring an endoscopy. So the current tariff, I think, would include them staying in hospital, having all the tests they need. A dynamic service would perhaps offer better blood transfusion, sending them home for 2 or 3 days whilst they're waiting for their endoscopy. And we can't afford to pay for that as an extra. So we have commitment to work out emergency pathways that make sense without it pushing extra pressure onto elective care. There will be some, but we have an agreement that we'll be closely monitoring that. Ideally, we would have had elective in there if that was possible, but I don't think that was possible within the resources we had available to deliver this. Any other questions? Shall I move on to the next section?
All guests have been muted.
So this will be perhaps a shorter section. I think I've got the... Okay, let's go back. So clearly, the hype is that this is an outcomes-based contract. It's something that I really believe in very strongly. And interestingly, Nick Hicks came along and spoke to about 15 or so Peterborough GPs last week and gave a half-an-hour presentation within a workshop setting. And I think it really did touch the bread and butter GPs around the table, and some of them have been saying that's what they've been thinking for years, that this is the way forward. So I think we are on the right lines. This will head the contract. Underneath it will be their solution that won the bid for them, translated into legalese into a standard NHS contract, and then all the specifications for community services will be documents that we can count on. So the outcomes framework, extensive public health literature search led by a consultant in public health, Kirstine Watson, modified from Porter's hierarchy. There were initially over 142 measures. We had external review and public consultation. We went out to public consultation for 13 weeks in June. We had permission, this is slightly unusual, permission from the bidders to publish an anonymised summary of their bids. I understand this is quite unusual. Otherwise, I think the public consultation would have been fairly meaningless. And clearly they were sharing commercially sensitive information. And part of that public consultation was reviewing the outcome framework. A lot of noise came back, too many indicators. There was duplication and overlap. Don't lose some process outcomes indicators. Map it to national voices. I'm sure you're all familiar with that. I statements around patients, for example, when they see a clinical professional, they want to have a sense that that clinical professional knows about their case and is liaising well with the team around them. And we did some rearranging. It's got 7 domains. The first one is a better experience of care. This essentially will be a questionnaire to patients, either in the community or those admitted or those discharged or those with long-term conditions. Safe care, the hospital-acquired infections, the usual things you'd expect in there. And well-organised care really is a euphemism for the cultural change that we're expecting to see. So we'll be asking their own staff, is this a good organisation to work for? Do they listen to you? Have you been appropriately trained in end-of-care, end-of-life care, etc.? So those 3 are overarching the whole pathway. Then the 4 pathway domains, keeping healthy. So that's the business of setting a contract around the population. So 140,000 people over the age of 65 in our CCG. And they'll all need to be risk stratified in some way. There's an intention, people age 65 by the new organisation, to be offered a health check as a sort of an entry, a sort of birthday present, and so on, all the way through to the top of the triangle, and the top 2% at risk. The next is treatment during acute illness or injury. So this is a euphemism really for offering frail older people a plausible and safe package of care at home when normally they will go into hospital. The 6th one is recovering from illness or injury, so that's all to do with rehabilitation. Too many, I think, of frail older people are going into long-term care. Clearly, local authority is particularly keen that we're successful on this. And then the 7th is the all-important end-of-life care. So The current Mark III version, which is available on our website, but we can send round to you with the slides, has 28 key outcomes across the 7 domains. Each outcome has several measures. How do you know that the outcome's been achieved? And they're a mixture of process and markers of health gain. I'll go through just a small number in a moment. Some of them are ready. We already have the data for emergency bed days, for example. Some need some baseline work, so we need to work with the new integrator to work out a baseline and what trajectory might be over the next 5 years. And some are actually need quite a lot of development, but we aim to get them all developed by the end of year 1. We will not be linking payment to outcomes in year 1, which we thought was only fair and pragmatic. And by the 5th year, 15% of the contract is linked to outcomes. Moving on. Oops. So I won't. This really just says the same. You can see there are 4 pathways with end of life in the middle, surrounded by those 3 overarching domains. So these are just some examples, just to give you a feel. So could be controversial, this, but we're going to incentivize them to improve HbA1s, a marker of good diabetic care, for those patients who are referred to their community services. So this is aligning the incentive to primary care around HbA1. So this is one where we will work together to get a baseline, and perhaps we might, for example, have a trajectory where we would average HbA1s improved by 5% a year each year over the 5-year period. These are complex patients, so they'll need an all-singing, all-dancing diabetic service with behaviour modification element to it to achieve all that. So the next one here is proportion of patients and carers report that they are involved with their care worker. So this will be, for example, on the question, involved with their care workers as a team, communicating well together and sharing information, coordinating care. So this will be on the patient questionnaire. So we fully understand that although there are valid tools, there are also challenges around questionnaires, particularly for frail older people. So we have challenges ahead to get this right, and we're going to work very closely with the new integrator to get some meaningful results. But we suspect actually it's the act of doing it which is more powerful. What do they do with the comments that come back? The 3rd bullet point there is similar questionnaire. So this is an interesting one. Patients and carers report that they were not in hospital or a care setting for longer than medically necessary, and the care was arranged and coordinated without unnecessary delays. I think hospitals have a long way to go to get the discharge process right. It can be from medical decision to discharge to actually discharge. It can take days, even when there are no social and care package problems. Assessment of whether patients in the hospital are receiving the right level of care, the clinically appropriateness protocol. So this will be around whether they're actually, for example, over-treating, over-investigating a dying patient and so on. Or maybe some patients not getting adequate levels of care, not enough. We're going to be asking GPs and local partnership organisations if they've noticed the difference. Some of the results of that will be linked to payment to the new integrator. So this is an example of a process marker. Do they actually get there within 2 hours? So perhaps naively, my ambition would be that as trust builds up and as this is successful, we can start dropping process markers like that. Because the other ones, I think, in my mind, are higher on the hierarchy of health outcomes. This is a better patient experience. Have they been able to remain independent for longer? And this is just a means to an end, and I would hope to be able to drop that in due course. About 15% of the metrics are up for discussion at the end of each year to keep them fresh and up to date. The next one is around the comprehensive geriatric assessment. So the concept here is that too many very frail patients are ending up in adult medical beds. They're under the care of a gastroenterologist on that ward, and we know they do much better on geriatric ward. And hospitals probably need to flip the proportion of medical wards looking after frail older people and reverse the ratio and include the consultants. There's a problem with recruitment of consultant geriatricians at the moment, but that needs to be addressed as well. And a really important one about people with long-term conditions, having joint plans, and the major part of the submission was using various resources to improve self-management capacity for our population. 18 and over is over 500,000, and we know probably about half of them have a long-term condition of one sort or another, if you include hypertension. The next one is around end of life, and which you'd expect in there with these two, really important. So in summary, it described the reasons why the services were a priority. Nothing new, I suspect, to any of you. The competitive dialogue method has provided pace and innovation. I've been involved in commissioning advice for over 20 years. And I was looking the other day at some old papers to throw them out. And I found a sheet of paper with exactly the same critical success factors that I showed you in an earlier slide. So we need to actually make the changes we've been talking about for over a decade. There's an integrator who's also a lead provider who will help to ensure a joined-up framework for provision across a crucial range of services for older people by working to an outcomes-driven contract. And the ideal is that these outcomes are shared across all providers, social care, primary care, and so on. And I think that should be a medium-term aim to do that. And we hope the financial incentives will get much better alignment and no longer be so perverse. Cultural change is critical. The length of contract should enable early investment, and the outcomes framework is intended to be a dynamic learning tool. I think we're just in the early foothills of what a good outcomes framework or contract should look like. So I think we all need to pour our expertise and our brains in order to help each other do that. So that's the end of my bit. We've got a few minutes if people have got other questions.
All guests have been unmuted.
Questions I might ask would be, our social services, finance is not included in this, and has your Better Care Fund money been focused on this, or have you got enough money to do it without including the Better Care Fund?
So, no, we haven't got enough money, so it's all had to be subsumed. And the powerful thing at the moment is all the work that we've been doing in terms of health and social care, talking to each other. We now have a third partner around the table, which is the integrator. So we're expecting to be able to optimise the use of that precious local resources. We're continuously in our local systems heading towards deficits. It's been a pattern over a number of years. So one example, these are the sorts of things I probably shouldn't be telling you about, but one example is in the successful bid. They're talking about joint health and care, healthcare assistant, care assistant level posts. In other words, train people so that they can do both the caring and some basic health checks as well at the same time. That gives you one example, one concrete example of how we can actually make better use of the very short health and social care monies. So there are a number of processes set up to join social care and health in terms of debate and talking and alignment. And both local authorities, Peterborough and Cambridgeshire, have sat on our Older People's Programme Board, and both of them are involved in the evaluation. And during the dialogue phase, we arranged workshops between the local authorities and the shortlisted bidders. Any other questions? Clearly, I've answered all of your thoughts and concerns and questions. Any other questions or reflections in the last 5 minutes?
My only reflection is the key to getting primary care truly involved, and whether they can do it without having some sort of risk share rather than just having an LCS. But you've obviously left that for the integrator to do.
Yes. So I take your point, and I think there's a lot of work to do there. I think if we're going to get proper joining up, then we need to somehow find a way of bringing our 108 local businesses into a risk-sharing arrangement. So it's not an easy task, especially when they're under so much pressure. Like, as general practitioners have in their hands quite the cost of the NHS in terms of referral, admission avoidance, and prescribing. I think keep a silos of provision as we have are just not sustainable into the future. So we need to work out models, perhaps in shadow form, over the next 2 or 3 years to see what we can do to change that. And has anyone got experience in that? So one question that we had was, what have been the changes in relationships with providers, if any, at this stage? So clearly the service commencement, we hope, will be the 1st of April, and there's a huge amount of mobilisation to do. Well, I've already noticed in the last 12 months a change in the way our 5 local incumbents approaching the idea of more joined up working. So I think we will see the benefits in the other parts of the NHS. So this is only 20% of our budget, and it still is 80%. And I think this will be an eye-opener in terms of the power of dialogue and challenge can actually produce some real change in attitudes. Okay. So any other questions or reflections? You can either speak them or type them out.
Only final comment would be that I think you're absolutely right that cultural change is the key to making this happen.
Yes. Over many years I've come to believe that very strongly. So we're going to make a huge effort, but I don't think anyone has got the rule book on this. How do you make that happen? But I think everybody seems to be up for it.
The only brave thing I think the integrator's doing is not to have agreement from the acute trust to drop PBR, because if they don't drop PBR, then there's not huge incentive for them to change their behaviour.
That's true, but I think they're going to have to be quite clever in the negotiations, because they'll want them to adopt some of the outcome metrics that they themselves may end up by being penalised for, or being rewarded when they succeed. So an example of that would be the emergency bed days, and I think it's in the interests of our four acute trusts, all of which have very serious problems, for this to succeed. So we include Peterborough, of course, with its huge PFI issues, Hinchingbrook, which is currently been rescued by Circle, and Adam Brooks has not been without its problems, and King Lynn is in serious problems. I think it's in the interest of the acutes for this to succeed. Okay. I'm going to turn back about next steps. And thank you very much, everybody, for listening, if you have been.
Thank you, Dr. Fertig. I think you'll all join me in thanking Arnold for a very insightful presentation and very informative of the experiences in Cambridgeshire and Peterborough. Just some very brief next steps. So we will make the slides from today's presentation available. We'll also send around a version of the outcomes framework that Arnold mentioned. Our next COBIC Club webinar will be on the 9th of December with Bob Ricketts, from Director of Commissioning Support Strategy and Market Development at NHS England. And we also have a workshop planned for January, so this will be the first workshop of 2015. So if you can save the date for that, and we'll send out some more information shortly. If you have any general questions on COBIC or on the COBIC Club itself, please do contact me or my colleague Carol Ann. Our email addresses are available on the slide, and as I said, we'll send it afterwards. So once again, just a final thank you to Arnold, and thank you all for joining today, and thank you very much as well for your questions. Okay.